Hi, everybody. It's Steve Simpson. It's July 9th, and so this is the Midwest Critical Care monthly meeting for July 9th. And thanks to everybody for joining. I see a lot of our stalwarts, and I really appreciate you guys being here. This is good stuff, and I don't know. Lee, you're on the line, I see, and I don't know whether you guys have a tool you use to let people know how they've performed in individual cases, but if you do, feel free to bring it up on your desktop, and I will turn it over to you in a few minutes and let you show us. Same with you, Carol. Belinda, anybody who's got one, speak up, and it'll be curious to see. I may make a special folder on the MW Crit Care website to put all of these into, so that other folks who join us can sort of pick and choose and see what seems to work for them. Let's see. So I think, Ruth, if it's okay with you, I'm going to pull yours up first, and let's see. So you said you like February 2015, April 2014, and we'll go in that order. So I will just pull this up, make it a little bit bigger maybe so everyone can see it. I'll go ahead and blow it to 200%. That works, and we'll 200's a little too big, maybe 150. Yeah, 150 fits us all. So Ruth just asked me if I'd go ahead and put them on my screen, which is why that's what I'm doing. So Ruth, you want to walk us through what you've done? I like the framework.
Sure, not a problem. And you had asked, how do we use this? Basically, how we use this SBAR format is we ask for team members to volunteer if they had a particular patient or scenario that happened in their areas. It could be the ED, the ICUs, med-surg. They thought would be an opportunity for learning. And I also, if we don't get one that way, then when I go through my audits, I look at opportunities as well and look for trends, so that way I can share with the team. Mm-hmm. And how we do this is a format we use during our monthly sepsis pit team. And then we also use this same format at our hospital-wide daily huddle. So it's shared throughout the whole Via Christi St. Francis, St. Joseph's, Lady of Lourdes, all the Via Christi hospitals within Wichita. So this is a format that we use to kind of spread the information and kind of how we're working. So when you look at this, S stands for situation, and in this situation we had a 60-year-old female who had a history of diabetes and hypertension, and she was visiting from out of town. And basically the patient family had shared that she's not been feeling well for quite some time, and they were concerned about her altered mental status. But she was a little older and she had a little bit of pain when she urinates, but that was kind of a new onset, and they weren't too concerned about it. But when they did the physical exam, there was definitely altered mental status, confusion with disorientation to time, location, and she also had quite a bit of abdominal tenderness throughout her whole abdomen. It wasn't just one quadrant or the other. So the workup, you can see that the blood pressure was 123/75, respiratory were 24, pulse was 114, and temperature was 104.4. So right away we thought, well, the source is probably the GU. And what happened is when we put that into our Cerner system, our computer system, a sepsis icon alert came up, and the ED has been very vigilant about any time that alert comes up, then no matter how the patient presents, we will go ahead and implement that sepsis bundle. So we implemented the sepsis order set and the antibiotic subset because we just got finished putting that order set together. And you can see what the lab was. The WBC was 13, blood cultures times 2. We did a UA. The lactic acid was 5.6. And we were kind of concerned because of her other reports from family as well. So we did a PCT, and as you can tell, the normal is 0.1, and hers happened to be 2.58. So we knew right away there was a definite infection. And the repeat lactic acid within 4 hours was 2.2. So we were very, very aggressive in regards to getting this started, because we also started the antibiotic and the fluid bolus right away. So the abdominal CT is what we did. She transferred to SICU, and we continued to monitor and provide care, and then we dismissed her 3 days later. So basically what we recommend is that we will continue to implement the sepsis bundle for every Cerner sepsis alert despite the presentation of the patient. And the reason I'm going to share that with you is because the next patient that I'm going to go over in a little bit in April is one of many that this has happened to. So, again, to the team, great job, quick thinking, and kudos in checking the PCT too. So therefore, we make sure we give the right antibiotic and being good stewards of antibiotics. So that's kind of a big combination of where we've been over this last year. So that's what that one looks like.
Cool.
If you go to the April one, this is the one that we use when we do patient education in regards to the importance of the sepsis. And that is, the situation here was a 66-year-old male. He had a history of hypertension, hypercholesteremia. He was visiting from out of town. He was brought into the ED for a possible head trauma because he was found confused, actually lying in a parking lot and at a hotel. And what kind of clogged us is, in the background, the patient and family shared that he had been feeling poorly for about a week with a mild cough, nausea, and abdominal discomfort. But the family was really upset because he had been drinking the night before, and they were really upset and thought maybe it was a head trauma. So on our assessment, the physical exam, there was facial abrasions, there was nasal tenderness, diaphoresis, confusion, and then had the right upper quadrant tenderness. But he wasn't complaining much about his head, but it was obvious in regards to his head injury. So the workup in the ED, blood pressure was 93/54, respiratory were 24, pulse 120, temperature 98.1. But then when they redid it rectally, it was 105.5. And we really, the source was kind of unknown at the time. We were thinking head because of altered mental status. We were thinking, so we implemented the sepsis order set in the bundle. And when we got the lab back, the WBC was 6.2. 10% bands, platelets 121, blood culture, you can see what it grew out, lactic acid was 4.2. And then the next morning they did the lab. They didn't do it within the 6 hours, they did it the next morning, AM lab. So we treated with antibiotics and fluid bolus, but to our surprise, after the head and CT and abdominal, we found out his head was fine, but he had a septic gallbladder. And chest x-ray was negative, so we transferred to SICU. The blood pressure dropped down to 74/58. We implemented fluid bolus with a good response, and then after he was stabilized, then we went ahead and underwent a lap cholecystectomy and revealed a gangrenous gallbladder and a gallstand impacted in the cystic duct. So we always give that, we like to give that scenario because how they first presented in the ED was not actually what happened. So that's why that quick observation and that keen eye and that clinical process and standardization of the 3R bundle is really, really important. So what we recommend is, this was a very sick patient that was treated successfully. We will continue to implement the sepsis order set bundle for every patient despite the presentation of the patient. Also re-educate the importance of repeat lactic acid when greater than 4, and we made significant progress, so thank you. So that's kind of how we set up our SBARs. And we can go to the third one if you want, but it's basically the same process. The only thing that we learned from this is February over a year ago, and this is one of the things where we picked up where we had an opportunity. So this situation was an 80-year-old female, history of renal failure and diabetes. She was at home not feeling well and had a cough, a little shortness of air, and was brought into the ED by one of the loved ones. So the background, the patient and family had shared, she's been feeling tired and couldn't get rid of her cough, and now she's short of air and kind of concerned because she's not able to go up her steps as much as she could before. So in the physical exam, she did have a call. She was short of air and a little dehydrated. So in the ED, you can see what we did. The blood pressure was 103/60. Respiratory were 28, pulse 120, and the 101.1. So we thought the possible source was pneumonia, and we implemented a sepsis order set. So kind of pay attention to that. We did the labs. You can see the WBC was 8 with 12% bands, blood culture ×2. The lactic acid the next morning in the AM lab, so they didn't run a lactic acid, was 4.2. We did treat with antibiotics, so what the chest x-ray revealed was pneumonia. So when they were in ED, they canceled out the sepsis order and implemented the pneumonia order set, okay? That was a mistake. I'll tell you why. We did transfer to the medical floor. We continued to monitor and provide care, and she was dismissed 2 days later. So our recommendations, we fell out of the bundle because of the lactic acid. We didn't do that within the first 3 hours, and our recommendation is to add lactic acid to our current pneumonia set. So what we did was, in our pneumonia back in February 2014, we did not have the lactic acid as a part of our pneumonia order set. So because of this type of case and other cases that I was seeing when we were trending, our pneumonia patients were falling out because the lactic acid wasn't being done, and that's when we made the change to add lactic acid to our pneumonia order set and make sure it was a priority to educate everybody. So those are just 3 examples. In some months, we didn't have good patient stories, but we did share them. We did talk about them, usually about 10-15 minutes, because we really needed to talk about the systems and the processes and what we could have done better. So hopefully this is helpful.
I think this is helpful, and I want to clarify exactly how you use this. So first off, you talk about this in your sepsis team meeting. Am I right?
Correct.
Okay. I feel like the gallbladder sepsis. That might have been what you were talking about when the day that I was there with you, because that's a really familiar story.
Yes.
So you talk in the team meeting, then do you take this to the individual doctors and nurses that were involved in the care of this patient?
Yes, definitely. Oftentimes that's what the physician lead would do. Dr. Stengel would do. He would sit down with the person as well as myself and say, hey, this is what happened. We make sure we get the whole story. That's why when we do the audits, we go through it. We talk about it at our PIT team meeting, because there could have been other variables involved. So we look to see if there's other barriers before we take and present the SBAR to the hospital-wide daily huddle. So we try to talk about it as a team, then we talk about it at the department level, and then we'll share with the hospital at the daily huddle, probably within that month or a couple weeks after.
Cool. Very good.
So I know, Connie, are you on? Connie's with us.
Yes.
Yes, I'm on. Hi, Dr.
Hi. You want to add Connie? We're so glad for her to be a part of you, Christy.
Yeah.
This is my first call in a long time, and I've really enjoyed it. Great job, Ruth.
Yeah, wasn't that good? So actually, I'll ask for volunteers before I show what we use at KU. Does anyone have one from your hospital that you'd like to show us? Not yet. Although it wouldn't shock me if Lee Toman has one, but Lee's having a hard time getting dialed in on the telephone for some reason. He keeps typing in the numbers, he tells me, and it keeps telling him he has entered no digits on the telephone. I don't know how that works. Exactly what's going on. So I'll tell you what, I will go ahead and move to what we use at KU. And now, unfortunately, Dustin Pierce, who is the nurse who coordinates the sepsis team with me here, is Well, unfortunately, I use the word unfortunately. Fortunately for him, he is in Alaska fishing for halibut and salmon this week. So I'm glad he is. and I hope he's having a good time. But so he's not here to tell you exactly how he extracts and what goes on. So I apologize that this does show some doctors and nurses' names. I don't have his source document. So Dustin sends an email that says, just like this, whenever there's a sepsis response team activation, Dustin sends this email, and it says, thanks for activating. This scorecard is updated to reflect the newest recommendations from Surviving Sepsis Campaign and CMS. It's a tool of discussion and performance improvement. They're not mandatory. Implementation of the bundle item may vary. We're just giving you the information. And it says, you provide excellent care to our patients every day, and we appreciate that. But so here's what you see on the scorecard. It gives patients' initials and medical record number, which I will hide. Then it tells when the episode occurred, why the sepsis response team was activated, the time they were activated, what time zero was and is, who are the attending, the resident, the MICU people, the attendings, the residents, the ED nurse, the ICU nurse, everybody who was involved in the early care of this patient gets a copy of this. So just to minimize things, I guess I will hide as many of those people as I can. Hopefully they won't mind their names being out on the web. So essentially what the scorecard has that's always here is our University of Kansas hospital goal. And it tells the time that any particular component of the therapy was completed, and it tells the time from time zero to completion on the scorecard. So on this one, rapid lactate drawn within 1 hour of time zero, so it was completed at 20:38, which is 18 minutes after the patient arrived. 2 blood cultures drawn prior to antibiotics, done at 21:15. That was 55 minutes. And our goal is that it should be done before the antibiotics are given. Broad spectrum antibiotics, this is our goal. And all of you may realize that the Surviving Sepsis Campaign, even though CMS accepts 3 hours, and even though they have a 3-hour bundle, they recommend that we get our antibiotics in under an hour from time zero. So it was completed at 21:22, which was an hour and 2 minutes from time zero. It was well within the new 3-hour bundle, 3-hour period. Initial fluid resuscitation was started 28 minutes in, and our goal is within the first hour. Resuscitation with 30 mLs per kilogram of crystalloid within 1 hour is the ideal. Took an hour and 25 minutes. Fluid goal met within 3 hours, which we call acceptable, was clearly met at an hour and 25 minutes. I don't know how I got lucky here. Dustin, I have dozens of these in my email because I save all of them when Dustin sends them out, and I guess I just got lucky on the 3-hour bundles. We did great on this patient. So bully for us. They don't all look this good, I can assure you. The follow-up, trending the lactates collected and ordered. It took an hour and 6 minutes to get the repeat lactate. If hypotension persists after fluid resuscitation, apparently it did not. So it's not applicable. Central venous pressure measured was not applicable. Apparently the hypotension dissipated after volume administration. assessment of volume administration was done. 3 hours in, my guess would be this is when the patient arrived in the ICU, probably used the NICOM to see whether they needed further fluids. Yeah, see, an hour and 25 minutes is the same time that it took to get the 30 ml crystalloid bolus in, so obviously responded to the initial bolus. SpO2 greater than 92% achieved and maintained by 25 minutes in. So this was actually a pretty good performance on this patient. So again, Dustin initiates this email, but the email and the form and everything comes from the sepsis team, which is me as the physician leader of the sepsis team, Amanda Gardner as Dustin's boss, and Dustin, who's the sepsis coordinator. So a scorecard like this goes out to everyone. Let me see if I can find another one. Sepsis response team activation. Well, close that, just go to here. Again, this is what the card looks like. Rapid lactate drawn. Looks like we did pretty good on the 3-hour bundle here, except look at this, resuscitation not done. It's, fluid goal. Actually, central venous pressure measurement not applicable. So it looks like this was a severe sepsis patient who wasn't hypotensive. Let's look here at another one. Similar thing. Get it a little bigger here. Blood culture is drawn before time 0. Isn't that interesting? How can that happen? Broad spectrum antibiotics started at 19 minutes. Initial fluid resuscitation started 18 minutes in, but the fluid goal doesn't appear to have been met. Lactate trending was done. Appropriate sepsis order set initiated at 2 hours and 21 minutes. And no shock was present. No shock, no shock, no shock. So these were not necessary. So there's 3 examples of our sepsis response team team management scorecard. Oh, good. Lee has audio now. Fantastic. And so this goes out to every time there's a sepsis response team, and then we collate all this data, of course, and track our performance over time. And it looks like just because you can see scores of these things here in my email box, that over time we are certainly doing better on the 3-hour bundle. 6-hour bundle remains to be seen. Obviously, you have to have a patient with shock for the 6-hour bundle to apply. And there we go. So this just goes out by email to every team. Lee, I was wondering whether you guys have something that you send to your treatment team that looks somewhat similar to this, or similar, that performs the same function as this. If your mic will work. He has audio, but he may not have a mic to work. Okay, and so I'm just going to check in on some folks. Carol, you say that you can't see the presentation. That may be, is that because you're on telephone or?
No, actually, I just now got it up on my computer. It wouldn't take any of the information before, but I'm actually using my iPad, and it's all gray. I can hear everything. I don't know if you can hear me or not.
Yeah,
but I now brought it up on my computer, so now I can just now see what you were showing. It took me this long to figure it out.
I'm sorry. Well, I will
That's all
have
right.
this recorded. Here's what the whole thing looks like with names and everything. Like I said, I'm trying to avoid showing the names as much as possible, just in case anyone might be aggravated by having their name on the thing. I tried to. Unfortunately, Dustin has the actual form that he fills out and sticks in here, and I didn't think to ask him before he took off for Alaska if I could get the original so that I could demonstrate it. What we will do, though, is I will get that from Dustin, and like I say, we'll make a folder on the shared ICU quality improvement files, and we'll stick this in there. Ruth, would you mind if we put your examples in that folder as well?
Yes, that's fine. I had it all approved through corporate responsibility and everybody, so it's ready to go.
Perfect. Good for you. And Carol, I don't know. Are you guys doing something like this where you get back to people with this was Mrs. Smith and this is how we did on treating Mrs. Smith?
I did. I actually send it to you. We don't do 100% chart audits. It's kind of
right.
I do hit and miss, or I do some of the bigger cases. But I have a form. It's very generic. I actually send it to you when I couldn't see the presentation.
Gotcha.
But it has the times in it. It has the nurse, the physician, and then I scan it in and I email it to all of those people. You know, if they met the times, because again we do the same as you do. We have antibiotics and fluids within an hour is our goal. But we do a lot of talking and a lot of educating based on those times.
Gotcha. I bet that went to my MWCCC address. Am I right?
It probably did, yeah, because I just attached it to the email of today's meeting.
Gotcha. Okay, I'll get logged in there and we'll.
It's very generic.
No, different account. MWCCC.org next. Sign in. Lovely. It's okay that it's generic. I mean, there are many different ways to skin this cat, and so that's why I think it's cool for us to look at everybody's different ones. Let's see where. There it is. Yeah, that's perfectly good. So, in fact, it's very nice and succinct. So you got your patient name, age, etc., who the admitting physician was the sepsis alert activated, some information about them, when did they get there, when was triage, were the SIRS criteria identified, sepsis bundle ordered. I love it. That looks very nice. And so, as you say, so you're not doing this on 100% of patients, but on as many as you can.
Right.
Outstanding. Yeah, so Lee says, you guys can read this down below, that he's somehow unable to transmit sound, but they do have a report card that's sent to physicians and nurses involved in the ED to ICU cases. Cool. That looks good.
On the back side of that, we actually have it's not on this one, I photocopy it. I actually put the tool, our sepsis assessment tool.
Oh, fantastic.
So when I send that back to the nurses, then they can review the actual tool and see, where they missed it. Our case that we had a couple weeks ago, I've done some case reviews with staff here on. They totally missed it. I mean, they totally, they didn't even think sepsis, and it ended up being septic shock, and then the patient did not have a good outcome. So
Yeah. I'm sorry. It is sometimes a long, tough row to hoe, I can tell you.
right.
It's well, as you know, I've been hoeing this row for the last 13 or 14 years in the state of Kansas, everywhere I get the opportunity. So I know exactly what you're saying. So,
Yeah.
Carol, would it be okay with you if I post this on our website as well?
Oh, definitely.
Fantastic. This looks really good. Belinda, how about you guys? I bet you have some way of getting back to people, don't you?
Oh, yes, we do. Actually, thanks to you, we pretty much just minorly altered it, and we send that out also with anybody that has had a septic shock or a severe sepsis patient.
Cool. So you mean one that's similar to what I showed from KU?
Yes.
Cool. Here's something that I thought that I would show you that is useful, especially if you're using the care improvement tool from the Kansas Sepsis Project. Again, everyone, I'm sure I've said this half a dozen times before, but don't panic. University of Kansas Medical Center is not the actual name of our hospital, so these are not real patients. But what a person can do is go to the patient tracker. So those of you who are using this tool know this. You can go to the patient tracker and you can, actually, I'm going to back up because I did it without pointing out what I was doing. Okay, back up. You will see at the top of the patient tracker, there is a little print icon. So when you click print, it gives you a short summary that looks just like this. So of course the summary, as you know, in this database doesn't have identifying information on it. You would have to inform the people you were giving to exactly who you were speaking of, but I think that actually makes this very useful. So you can send in your email that's probably encrypted internally, I bet, like ours are. You can send in the email, this was Mrs. Smith with medical record number, whatever the number is, and attach this report for were these things performed and achieved in Mrs. Smith. So it's not as succinct, I think, of a document, but it does ask the question and gives yes or no answers whether this was achieved or whether it was not achieved. So if you're using this tool, I think that you may want to consider doing it in this way. I wish Lee could transmit sound because I'm sure that Lee has intelligent comments to make, but that's the way it goes. So Lee, I gather that even the telephone in this new office isn't working. That's too bad. All right. So people who are on, say, Pam Anderson or Katerina Rines, how about you guys? Do you have a tool that you're using?
This is Pam, and we have a spreadsheet that we send back to the, most of what our work has done so far has been at the emergency room, not so much. We're kind of getting started more on our inpatients, but a spreadsheet that we can send back to the physician and the head of the emergency room who follows up and kind of with the people involved to let them know how we did on our treatment of our patient.
Fantastic. If you wanted to send me a screenshot or something of your spreadsheet with the names blanked out, I'd love to stick it up too, because I think the nice illustrative thing here about this particular exercise is that there are multiple ways to get at providing the information back for our providers. And
Okay, we'll send you that.
Cool, that'd be nice. Yeah, and there are multiple ways. The key thing is get the information back. Make it in a form that's readable and easily understandable, but get it back, because no one even purposes themselves to improve their performance until they see how they are performing. Because I don't know if you guys are all like me, but until we started actually tracking, really tracking, I think most of us in my pulmonary and critical care division believed that we were doing a great job. Oh, here's a message from Lee too. He says, in addition to the report cards to individuals, we send a summary of bundle compliance to all, sometimes adding a case informative to all. That's cool. Outstanding. Okay, good. Well, so I think we've covered this, and I think it's encouraging to hear everybody that's on the line is doing this. It's really nice. Connie, by the way, I've been in touch with your replacement at William Newton. Any backward support or encouragement you can give them to jump in with both feet, I would really appreciate it, because you had a really good start there in Winfield, and I hate for that start to kind of sputter.
Okay, will do.
I'd appreciate it. Let's see. Okay, something else I thought I would show you guys here is something I got from Dustin, and I used in our critical care committee yesterday. And you all may actually like the whole presentation, and I will ask if it's okay for me to get the entire presentation out on the web. But this is and you guys already know all this, but you might find, I thought Dustin put together a nice presentation discussing what the new aspects of the core measures will be as of October 1st. And again, I'm going to go through this quickly because every one of you on this call knows what they're going to be. And I think, though, and he's got some good details about what data needs to be extracted and from where it will be abstracted. So I'm sorry if I'm going through this really fast. What I'm hoping to get to is he has a really good summary slide that if I were you guys, I would copy this just to get to all the members. You might even want to make a poster that looks something like this so people know this. But I thought he did a really nice job here of getting summarized onto this one slide. So within 3 hours of presentation, lactate, broad spectrum antibiotics, blood cultures drawn prior to antibiotics, crystalloid fluid initiated. Did the hypotension persist? If yes, then you have to do this. If hypotension did not persist, then you've met your core measure goals. Remeasure the lactate within 6 hours if it was elevated. If the hypotension is persistent, they need to have if hypotension is present, they need to have a 30 ml per kilogram of crystalloid fluid bolus. Evaluate the need for vasopressors. And then here are your means for tracking cardiopulmonary response. We have talked about this before. Again, just to reiterate, even though you guys probably do know already, reassessment of volume status and tissue perfusion, the focused exam by the licensed independent practitioner has to include these things: vital signs, cardiopulmonary exam, capillary refill, and this, yeah, actually I'll show you our own scorecard for ourselves here, peripheral pulse evaluation, skin examination. Has to be a physician, ARNP, or PA. And then so one of the big questions that comes up here at our place is a resident a licensed independent practitioner? Part of that question is easy because an intern most assuredly is not. They have a temporary license from the state. All of our residents obtain a permanent license from the state at the time they enter their second year of residency. It's part of what our GME committee does. And so they are indeed licensed independent practitioners, but the question is, if they are functioning in their resident role, can they be considered a licensed independent practitioner? And this will apply at Via Christi as well, I expect, what the answer to that question is, and we are still trying to come up with the exact answer, because that
Who
would
have you
make...
reached out to, Dr. Simpson?
I'm sorry, say again?
Who have you reached out to for that
Well,
clarification?
we're working through our GME committee to talk to the Board of Healing Arts, to the Board of Healing Arts and the ACGME to get a determination. So you can imagine if somebody presents to the ER and, presents to the ER and gets some of these things done and comes to the ICU, and the resident then does a complete physical exam, as long as it includes these things, then that would count for your reassessment if the resident can be counted as a licensed independent practitioner for this purpose. And we have our hospital's legal people, and we actually have a meeting coming up where we're going to discuss this and settle at least on our hospital's policy. We may have to contact CMS to see what their determination is on that as well. In fact, we probably had better, don't you think? It doesn't much matter what our determination is if CMS doesn't recognize the validity of it. So I think we are going to have to reach out there. What was I going to say? So that's the exam, and then 2 out of 4 of the following. If nothing else, I think this would make a great poster to have available for everybody. So I will ask if it's okay to post this on the website as well. I'm certain that it is. Actually, this is the part the hospital may not want us to necessarily post permanently out there. So Dustin did a screen on 20 total patients. Dustin and Ann O'Donnell, who does our is going to be our core measures extractor. So what have we been doing well? Having the first lactate drawn, having the second lactate drawn within 6 hours, that's going well. Having the blood cultures within 3 hours, and having the antibiotics started within 3 hours. Only 6 of them had it started within an hour. 19 of 20 had the crystalloid fluid started. Okay, so that all looks pretty good. We're sort of pretty good at the 3-hour bundle. But where are we falling down is that in the people who were hypotensive, the 30 total of 30 mLs, they got their boluses, but the adequate volume was not given. Only 2 of those 9 had 2 of the 4 volume status measures completely. 0 of 9 had the focused physical exam completed. Now remember that on that physical exam, every single element has to be complete, or the exam is not counted as correct. And this is where we are falling down. Capillary refill. Something that physicians, I think, in general, are not used to documenting in their physical exam, so they are not documenting capillary refill. So that prompts us here to say what we need to have is a couple of things. One, on the admission history and physical, in the event that our residents turn out to be considered licensed independent practitioners, that we need to have that template modified so it includes a blank for capillary refill, which would prompt people to put it in there. Or we need to have a separate template that's not part of the physical exam, that is the focused cardiovascular exam, which would include all of the elements. And so far we are not settled in on exactly which one of these we're going to do. So here's another question from Lee. I just opened up our questions. He says that he may have missed it. No, you didn't miss it, but are you going with CMS start time and MAP threshold of 65, or using both CMS and SSC criteria in separate data fields? Yeah, so SSC considers blood pressure or a MAP less than 70 to be low, and that should prompt resuscitation. And CMS adopted a MAP less than 65, and I think, Lee, this is what you're talking about. So the question is, which one would you go with, or would you go with both and keep them in separate data fields? And I'm going to I think we have not made up our minds on that. We're going to have sepsis team and quality improvement team get together and decide which is it that we need to or should do. Obviously, if we go with CMS, then there are a few people who won't get fluid boluses, but we will meet CMS criteria. And the question is, what's important here, meeting CMS criteria or treating the patient? I think all of us here on this broadcast would focus on the patient first and then the CMS second, which I believe is the appropriate thing to do. CMS actually, all they're trying to do is help us to be sure that we take appropriate and good care of our patients. So they are not and should not be faulted at all for putting this. In fact, as I've said before, I'm so completely happy that CMS has finally gotten in the game by providing some core measures. And whether there are a lot of critical care docs, as you know, who are not certain that they agree with these core measures, agree with these criteria, and they have made somewhat of a ruckus over it. But nonetheless, having a baseline here for performance, I think, is a really, really good thing that has been needed for a long, long time. So that's how we do on it at KU. For severe sepsis, we were 100% compliant on 16 out of 20 cases. For septic shock, we were 100% compliant only in 2 out of 9 cases. Neither one of which had their hypotension persist after the initial 30 ml. Yeah, so where we are where we are falling down is in the area of follow-up in the septic shock patient. So I think a fair number of people are fairly worried about our ability to meet the bundle in the 6-hour case. But I say, great. I'm glad a lot of people are worried, because we need everybody on board in order to do this. Yeah, so this is some things that Dustin proposed that we might want to do in terms of chasing 100%, and I think that's it. But what I at least want to get, I'm pretty certain that Dustin will let me post this one, because like I say, this would be a great thing to have hanging on the wall that says, guys, this is what we have to be compliant with.
So Dr. Simpson, is it okay? Are you going to get copyright approval, or do we need to submit that to use this? Because this is wonderful. This is awesome.
Yeah, this is awesome. No, I don't think anyone cares about copyright here for this. So when I say get permission, Dustin's going to say yes. I just think that it's a technicality to get his permission because he's going to say, of course you can use it. But yeah, and the only thing that's copyrighted on here is the magnet recognized University of Kansas Hospital, yada, yada. If you wanted to copy this slide and put it, in fact, you know what I might do is copy this slide onto a blank slide template and post it so that it's readily available and you can adapt it. You can put Via Christi on the bottom if you want. Well,
I'm okay with that on the bottom too. That way we know we're being compliant as well.
Yeah.
But just in case my branding at Via Christi asks, I just want to be prepared to make sure it's okay.
Yeah. Okay. Yeah. And would KU mind? I mean, yeah. I don't know. I'll tell you what. I'll get it posted. And I cannot imagine that KU would mind, especially since we're embarked on the DISREP program, which is trying to get everyone in the state to follow these particular measures. So that's what it's intended for, is for us to show to doctors and nurses in every corner of the state. So I can't imagine that they would mind if you printed it up at all. I'll figure it out. Okay. Guys, that's about what I have for today. And I guess we're 5 minutes before quitting time, but what the heck? Is there anyone who complains about having 5 extra minutes in your day?
No?
Yeah, I didn't think so. All right. Hey, Ruth, thank you so much for showing us your tool. Carol, thanks so much for showing us your feedback tool. These are all great. I'm going to get them posted. I'll put a folder on the Midwest Critical Care website in the usual place, and we will get them all there and make it so we share what we're doing so other people can do better at what they're doing. And that's all I've got for today. Everybody have a great Thursday and a great month, and we'll see you in August. Oh, I always do make sure to say when the next one's going to be. So let's pull up a calendar here and look. August meeting will be an evening meeting, so 6 p.m., and it should be August 13th, Midwest Critical Care Collaborative Meeting. It says it right here. So I will see you guys all on August 13th, and have a good summer.
You too. Bye-bye.
Thank you. Bye.
Bye-bye.